Good afternoon. I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital, Somerset. Welcome to today's webinar on COVID-19 strokes, a dual connection, presented in collaboration with Friends Health Connection. COVID-19 is a respiratory illness, but over the past year, we have learned that it can have more far-reaching impact on the body in addition to the respiratory system. Recent research has shown that COVID-19 can increase an individual's risk for stroke. Those who have had a stroke are also at a higher risk for complications from COVID-19. During today's webinar, we will learn more about strokes and their connection to COVID-19, as well as the signs and symptoms of stroke, diagnosis and treatment options, and how to prevent a stroke. We are pleased to be joined today by Dr. Srinivasa Potluri, a neurologist with Robert Wood Johnson Barnabas Health Medical Group and Robert Wood Johnson University Hospital, Somerset, and Laura Smith, a registered nurse who is the neuroscience program manager at Robert Wood Johnson University Hospital, Somerset. We will begin our webinar with 20 minutes of a moderated discussion, followed by questions from our audience. So first, thank you both for joining us. We appreciate you taking the time to share invaluable information with our audience. So maybe we can start by each of you telling a little bit about yourselves. So why don't we start with ladies first? So Laura.
Hello, good afternoon, everybody, and thank you for having me, Serena. So yes, my name is Laura Smith. I am a registered nurse here at Somerset. I've been a nurse now for 21 years, and the majority of my career has been dedicated to stroke patients. I am the neuroscience program manager here, which means I help to ensure that our stroke patients receive good, high-quality care, which helps to improve our patients' outcomes. So May is Stroke Awareness Month, so I think this is a very important topic that we're covering today. So thank you so much.
Thank you, Laura. Dr. Potluri?
Yes, hi, good afternoon. Thanks for asking us to join you guys, and I'm really happy to do this. These are interesting times, and we'll be happy to answer any questions that the community has. I have been in practice in neurology for the past 20 years. I've been an attending neurologist at the hospital for the past 16 years. And I also happen to be the medical director for the stroke program, having the real world experience of seeing and treating and helping patients who have had stroke at the hospital. So I'm glad to be of any help today.
Great, thank you, Dr. Potluri. So Dr. Potluri, let's start by maybe having you tell our audience like what a stroke is and what happens in the body.
Yes, happy to do it. So stroke is technically brain attack, just like a heart attack would be affecting the heart. Stroke would be a brain attack, and there are two types of stroke. The most common one, seen about 85% of the time, is what's called as ischemic stroke, and ischemia implies that there is insufficient blood flow to the organ. So the organ of interest here being the brain. And that lack of blood flow causes tissue injury because the brain depends on incoming blood flow to bring in the nutrients, including oxygen, that it really depends on to survive and function. So ischemic strokes are from lack of blood flow. And then you have the second type of stroke called the hemorrhagic stroke, which is from a brain bleed, where blood leaks out into the substance of the brain from inside the blood vessel, and that causes tissue damage from just the pressure of the blood leaking out, as well as the inflammation triggered by the products in the blood that don't belong within the substance of the brain. So those are the two types of strokes. The ischemic type, which is the more common one, usually happens from a blood clot within the blood vessel that's plugging the blood vessel so that blood cannot flow through. And that is the reason for the lack of flow to the brain. And such clots can form either within the blood vessel of the brain itself, or could have come to that location from elsewhere. Usually the heart would be a common source for these clots to travel up to the brain. I hope that answers the question.
Yeah, no, thank you. That was perfect. So as we've mentioned, we've actually seen an increase in stroke cases during COVID-19. Why is that? And what is the connection between COVID-19 and stroke?
Yes, so as you stated earlier, COVID started off being a respiratory illness, but very quickly we realized that it leads to inflammation everywhere, inflammation primarily in the blood vessels, as well as in the so-called endothelium, or the inner lining of the blood vessels. And blood vessels are everywhere. Now, the brain has blood vessels coming to supply nutrients and oxygen to it. And when the inner lining of the blood vessel, the endothelium, which creates a very smooth, even surface for the blood to flow in what's called as a columnar fashion, so in columns, smooth columns, when that flow is disturbed because there's now inflammation in the endothelium, that can trigger clots to form anywhere in the body where there is blood flow. And that would include the brain. So we've seen patients who have had stroke as a result of the inflammation, which is part of the process that the body goes through with the COVID infection. The second possibility is that there is also excessive stimulation of the clotting mechanism in the body, and that unfortunately can lead to clots forming in the blood vessels to the brain, usually within the substance of the brain. And more recently, we've also discovered that this clotting problem can happen not only on the incoming side of the blood flow, on the arterial side, but also on the outgoing side, where the veins tend to end up having clots within them. So there's back pressure on the brain, and that causes a stroke as well. And then the inflammation that is part of the process can lead to multi-organ failure. Thankfully, it's not as serious a problem in the pandemic at this point, because we seem to have figured out how to handle that inflammatory cascade. But inflammation leading to multi-organ problems, leading to a stay in the ICU itself from any cause, including COVID, can also set us up for complications such as heart attacks and strokes. So those are the potential causes and mechanisms that can lead to stroke in the COVID pandemic situation.
Okay, so thank you. You gave us a lot of information. So just to kind of clarify and kind of repeat, but let's focus in on who is most at risk for having a stroke.
Yeah, so the risk of COVID, increasing the risk of a stroke, is highest in patients who, or those of us who to begin with have a high risk of stroke. So that would be basically those of us who have had so-called vascular risk factors. And the big ones are uncontrolled high blood pressure, poorly controlled diabetes, elderly age, smoking, and high cholesterol. Any previous history of stroke, and any known problems in the circulation to the brain, such as blockages in the carotid arteries. And then any history of a vascular problem elsewhere in the body, say the coronary arteries to the heart or the circulation to your legs. So these are all triggers for vascular events. And those remain the most common underlying factors that increase the risk of stroke during going through the COVID process.
Okay, so then knowing that who's at risk, I know you mentioned some of the causes, but to clarify, what are general causes of stroke?
Yes, so generally speaking, I think the most important and treatable, modifiable, preventable causes of stroke, that's what we need to focus on. And those remain just staying on top of taking care of our general health, right? That would include seeing our doctors, making sure that we check our blood pressure, make sure that we check our cholesterol, our sugar levels, and manage them with help from our primary care doctors. I think that is the most important, modifiable, treatable, and addressable cause for stroke that we need to stay focused on. And that does not require us to go to the hospital. We have access to our primary care doctors, either in the offices now or via telehealth visits. And we need to really stay focused on that, taking care of our general health, taking care of our body health needs by exercising regularly, sleeping well, making sure that we promote our immune system's function by getting restful sleep, and exercising and socializing as best as we can so that we work on the general stress levels, which have been pretty high for all of us, with the start of the pandemic.
Thank you. So I don't know which one wants to take it, maybe Laura, because I see a sign behind her. My next question was going to be, what are the signs and symptoms of a stroke?
Yeah.
So
I can take that one. So the signs and symptoms of stroke are best remembered by remembering the letters and the words "be fast." So stroke happens suddenly, and that's something that we want to kind of enforce here, or encourage you to remember. A stroke does happen suddenly. So the letters "be fast" stand for, each letter stands for a symptom. So B is for balance, a sudden interruption of balance when you're walking or when you're sitting. E is for eyes, so that's for changes in vision. F is for the facial droop, especially on one side. A is for arm weakness, especially on one side of the body, arm and leg weakness. S is for speech difficulty. It could be slurred speech, garbled speech, inappropriate speech, maybe misunderstanding speech. And then T is time to activate 911. So the T is very important. We want you to know, as a community member, that it is safe to come to the hospital. We need you to call 911 if you experience any of these symptoms. Stroke is a medical emergency. So just remember the acronym "be fast," and that helps you to remember those symptoms.
So great point, Laura. So, during the COVID-19 pandemic, many people delayed getting medical care. So why, you mentioned don't delay. Why is it critical that anybody who has these signs of a stroke seek immediate medical care?
So the reason is because we can potentially treat the patient that's having an ischemic stroke. So Dr. Potluri talked about the two types of stroke. The type of stroke that is more common is caused by a blood clot, and we can potentially give medication to break up that blood clot, but we can only safely give it within 4.5 hours of the symptoms starting. So it's a very time-sensitive type of treatment. There's additional treatments we can offer, potentially a surgical treatment that also is very time-sensitive. So it's always very important not to ignore those symptoms and to get to the hospital right away.
Okay, thank you. So, I know because of COVID-19, like you said, many people were delaying care, but, the hospital has really taken a lot of safety precautions. So can maybe one or both share what are the safety precautions the hospital has been taking during the COVID-19 pandemic? Laura, do you want to start?
I can start. Yeah, I obviously worked through the whole pandemic. I feel the Robert Wood Johnson Somerset executive leadership did an excellent job keeping our staff safe. They really put our safety at the priority of their agenda, along with our patient safety. We have plenty of PPE here, personal protective equipment. We had lots of equipment coming in, at the height of our pandemic. But also patients were kept safe. Each patient is tested and screened for COVID if they are going to be admitted to the hospital. So anybody prior to leaving the emergency department will be screened and placed appropriately in the hospital. So I really have felt safe and protected here during the pandemic. So I think they did a really good job.
Yeah, and I completely echo what she just said and what Laura just said. The priority has been safety of the community, safety of visitors, safety of patients, as well as employees. And the hospital has done an excellent job. We have sufficient amounts of personal protective equipment. Isolation protocols have been streamlined, and everybody knows what to look for, what to do. But within the bounds of all these protocols, the most impressive feature I notice when I round on my patients is the empathy and the kindness that the staff have constantly shown to all of us, to each other, to our patients. Providing that personal touch, the physical touch, the gentleness and the care has been just astounding. Hats off to our nurses, especially. Just been so impressed, and I'll be really thankful for this to end, and I'm sure we all feel the same way. But to sustain this degree of care through all this has been remarkable, and hats off to our nurses.
Great. Well,
Thank you. Yeah, I agree. I think the nurses really stepped up to the plate, especially our critical care and emergency department and our floor nurses. Everybody, I mean, environmental, housekeeping, supply services, everybody has really done their best to make sure our patients have been well taken care of. And, we empathize with the family members too, that our visitor restriction was very difficult on them. We totally recognize that. So I agree. I'm hoping that we see an end to all of these restrictions soon, and we can let our families be with their loved ones while they're here.
Yeah. But unfortunately, those restrictions are necessary to keep everybody safe and to prevent any spread of COVID. So thank you both for sharing what is being done to keep patients well. So Laura, you mentioned when patients come here, can you maybe tell us about what patients can expect when they come to the hospitals with the signs of a stroke, and maybe who is part of a stroke response team?
Sure. So if someone does experience stroke symptoms, so again, that acronym is BFAST, we do implore you to call 911 if you are in the community. Our EMS services also, are trained to recognize signs and symptoms of stroke. So if you do activate 911, they do call us ahead of time and kind of let us know that you're coming. But if you do happen to drive in and you come in through our triage, you will be greeted. We want you to let us know what your symptoms are. And if we do recognize signs of stroke, we will activate our stroke team. As Dr. Potluri mentioned, stroke is time sensitive, and I mentioned as well, it's very time sensitive. So any way we can save time for the patient will benefit. So once you arrive, you will be greeted at the door by the physician and a nurse, especially if you come in through an ambulance, and we will take you off to CAT scan. And CAT scan is where we take a picture of your brain to determine whether or not you're having that bleeding type of stroke that Dr. Potluri was talking about, or a stroke caused by a blood clot. So it kind of makes our decision for treatment, based on that scan. And that's kind of what will happen as soon as you arrive, so that we can kind of make a quick determination for treatment.
Great, thank you. So now Robert Wood Johnson University Hospital Somerset offers teleneurology services in the emergency department. Can you tell us more about how that works and what the benefits are to patients?
Yes. So teleneurology is a really quick, excellent way for us to get a stroke neurologist to the bedside to make decision for the treatment. So our teleneurologists do work in tandem with our ED docs in order to examine the patient. They are able to see the radiology images that we have just taken. And that way they examine the patient together with the ED physician and make that call for treatment. If the patient does require a higher level of care, they help us to coordinate a transfer to our comprehensive stroke center, which is located in New Brunswick.
Okay. And normally, and correct me if I'm wrong, so this would be used, so, Dr. Potluri's on a 12-hour shift, needs to go home and get some rest, and he's no longer on site at the facility, but we might have a neurologist maybe at a different location that this service is then used. Is that correct?
Yeah, so our neurologists do see patients in clinic, and Dr. Potluri can speak better to this, but our teleneurology service is just a really great way to get a stroke neurologist to the bedside right away to examine treatment for acute stroke right, very quickly. So we've had some of our neurologists have attended code strokes and helped to make decision, but this is just a very reliable, quick, efficient way to get a neurologist to see the patient quickly.
Perfect.
Yeah, absolutely. We try to get a neurologist who has special expertise and interest in stroke, seeing the patient within 20 minutes. And sometimes that's not possible. If, say, I'm rounding on the floors, I'm in the ICU, I might be in the office. So having that option has really sped up the process, because we know that stroke care is time sensitive and we want to make the decisions fast and do what's best for the patient as fast as we can. The hospital has signed up with this teleneurology service several years ago, recognizing the need for this to really speed up the process. I believe we're one of the first hospitals in Central Jersey to do this, and it has really sped up the whole so-called door-to-needle time from symptom onset to when we provide care, when we provide the medications, has really gotten shorter with this particular intervention from the hospital.
Thank you. So here, correct me if I'm wrong, right, Laura, we are a primary stroke center. So can you share with our audience, what does it mean to be a primary stroke center?
Yes, we are, and we're very proud of that. So Robert Wood Johnson Somerset is a primary stroke center. We are certified by the Joint Commission. We did just complete our stroke survey in early March of this year. So what that means is that we have resources and processes in place to care for acute stroke patients. Our nurses and our physicians receive the stroke-specific continuing education every year. We have designated stroke units in which those nurses receive specialized training in neurological assessments, such as the NIH stroke scale. And research does show that when patients do receive care in a certified stroke center, that they do have higher incidence of survival and recovery than those treated in centers that do not have that designation. So we are very proud of our program.
Fantastic. Now, I know we've talked about teleneurology and, trying to looking at whether and diagnosing whether somebody has a stroke. But Dr. Potluri, can you really explain how a stroke is diagnosed?
Sure. So when there is a neurological symptom implying brain injury, that could be a stroke, and especially if the symptoms start quickly. So quick onset neurological symptoms generally require assessment for stroke. And what would happen is that, if somebody comes to the hospital with such symptoms, and the symptoms that Laura had mentioned earlier are the ones that, that we look out for, then the first thing we do would be a CT scan, a fast CT scan of the brain that helps rule out hemorrhage in the brain, with a high degree of confidence. So that helps us determine that this is not a hemorrhage. This is not a process that is different from what we need to do for ischemic stroke. Once we do that, then we go ahead and usually also try to look at the blood flow to the brain, look at the blood vessels to the brain by doing what we call as a CT angiogram. And that can be done in the emergency department. It is often done in the emergency department. That gives us a really good sense of how the blood circulation to the brain is. And that can help make important decisions, such as, should we transfer the patient to the Comprehensive Stroke Center at Robert Wood Johnson, New Brunswick, for advanced invasive treatment plans, such as so-called endovascular therapy, where the specialist can go into the brain using a catheter and do several things. They can use clot-busting drugs inside, they can pull the clots out, they can break up the clots. There are many, many tools available that we can utilize. So that's the usual flow that we are trying to accomplish when somebody walks in with stroke-like symptoms. Get this all done as fast as we can. If we don't need to transfer the patient, we do use an intravenous clot-busting drug called TPA, alteplase, that we provide for patients in our own hospital as soon as we can.
Thank you. I apologize. I had to take a sip. I had a tickle in my throat. So I know you mentioned two types of strokes, hemorrhagic and ischemic. I always struggle with pronunciation, forgive me. But are there any different types of stroke, and how does that differ from a TIA?
Yes, so a TIA stands for transient ischemic attack. Now, commonly, in common parlance, we also use the word a mini stroke. But technically, stroke implies that there has been tissue injury. So for example, on an MRI scan, we might see that there has been tissue injury, and by definition, that would be a stroke. Sometimes, though, the symptoms can be transient. So you may have temporary weakness, you may have temporary vision disturbance, you may have difficulty speaking for a few minutes. And these all imply transient ischemia or transient lack of blood flow to the brain. We do take that symptom very seriously, though, because that could be a harbinger of a future stroke. Usually in the near term, in the next 2 weeks, is when the stroke risk is highest. And we try to look at all the potential causes of such a TIA and fix what we can as quickly as we can, so that the patient doesn't have to deal with the subsequent stroke. So a TIA would be transient symptoms. Not every time somebody has a TIA would we end up with a diagnosis of a stroke, though, but sometimes we do based on the MRI findings. The symptoms are transient. The mechanism for the symptoms, again, is usually insufficient blood flow from, say, a blood clot, but the body's defense mechanisms end up breaking up the clot in time to prevent permanent symptoms and tissue injury. Symptoms go away, but then the risk stays. Why did this happen? How do we prevent this from happening again? How do we prevent this from the next time progressing from a TIA to a stroke? So these are the questions we ask ourselves, and we do the appropriate tests to see if we can come up with answers and help the subsequent event.
Okay. Now, I would have to imagine that based upon the different type of stroke, there are different type of treatments. So what are the treatment options available for strokes?
Sure. So, well, let's talk about TIAs and then move to strokes. If you see a TIA, we typically look at the pipes and the pump. That's how I look at it. So we want to look at the pipes that carry blood to the brain. You can do that with CT angiograms, MR angiograms, ultrasound Doppler. There are a few tools we have at our disposal to do that. The most manageable, treatable, preventable cause in terms of the pipes issue would be a blockage in the carotid arteries in the neck. If we see that and we believe that that is the source of the TIA, then we have a few options. We can use medications. We can call a vascular surgeon to talk about surgery to remove the plaque to allow more blood to get through. We can speak to a vascular surgeon or a cardiologist or a specialist neurologist about stents in these blood vessels. So those are the options for that. Then talking about the pump, the main cause from a pump perspective, the heart perspective for a stroke would be a condition called atrial fibrillation or AFib. It's a rhythm disturbance of the heart. Many times patients may not have heart complaints, but they may simply have strokes from clots from the heart breaking off and getting up into the circulation and hitting the brain. So if we see that, then the risk of stroke can be dramatically brought down by 95% by using blood thinners like Coumadin or the newer medications like Eliquis, Xarelto. So we talk about that. We then get the input from our cardiology colleagues. And then when we move on to ischemic strokes, which are basically TIAs that just never left, they just stayed. Again, we look at the pump, we look at the pipes, but then we also have to think about how do we help the patient get better? And majority of the time, it's managing certain risk factors that increase swelling of tissues in the brain, high blood pressure, diabetes. We have access to excellent rehabilitation services at the hospital, and Laura can definitely pitch in here and speak more about it. We have a physical therapy gym on the floor. We try to mobilize the patient. We try to make sure that their swallowing functions are intact. It's safe to feed them. We pay attention to nutrition. We pay attention to hydration. So we do all that. And then we have the hemorrhagic stroke, which is from blood leakage into the brain from brain hemorrhage. And there, the crucial provider would be our neurosurgeons. We have 24-hour coverage from excellent surgeons at the hospital, and we get their help. And is this from, say, an aneurysm? Is this from a primary brain hemorrhage? If that's the case, why did this happen? Now, do we then get in there to either suck the blood out or do other interventions to release the pressure on the brain? What medications can we use to control the swelling in the brain? And we have neurocritical care providers who help us out with that. We look for aneurysms by doing angiograms, and if we find one, then there are many ways of treating them, including surgery, but also endovascular interventions where using a catheter one can prevent leakage from these aneurysms. We monitor blood flow to the brain. We monitor swelling in the brain by using pressure gauges in the brain. A lot of interesting stuff can be done that can help the patient and hopefully lead to good outcomes. And these are all streamlined. So we are a stroke center. We have thought about these situations. We have thought hard about what we can do to improve the outcomes for the patients. We have thought about what we do in the ER, what do we do on the floor, what do we do in the ICUs, when do we get help, when do we send the patient out to a comprehensive center, and that is what a certified stroke center does, and that's what we are in Somerville.
Great. So thank you so much. Now, you had mentioned rehabilitative services. So I guess, Laura, maybe you could field this one. What type of rehabilitative services are available for patients who have had a stroke?
So every stroke patient that is admitted to the hospital is seen by a member or members of our physical therapy team, whether it's physical therapy, occupational therapy, or speech therapy, depending on the patient's needs. Each patient is evaluated for their needs after discharge. Our length of stay in the hospital, depending on the patient, is not significantly long. So we do want to get the patient out as quick as possible so they can start their recovery. So they are evaluated. Every single stroke patient is evaluated for their need, whether it be inpatient rehab or outpatient rehab or even home physical therapy. So depending on the individual need and safety eval of the patient. And we do have a PT gym right on the unit, like Dr. Potluri said, and we do have excellent services offered in-house. We have outpatient rehabilitation here offered as well at Somerville, here in Somerville. And then there's good facilities, surrounding the area.
Thank you. So now, Dr. Potluri, are individuals who have had a stroke at a higher risk for complications from COVID-19? And then what can people do to protect themselves?
Yes, absolutely. So it turns out that if you had a stroke once, then your risk for a future stroke would be higher if you had not had a stroke in the past. And that risk tends to be a bit more compounded by these inflammatory states from COVID. So the first thing to do, obviously, would be to stay safe. And I believe that we should all get vaccinated. The vaccines work very well. And in the hospital has been very, very proactive in participating in vaccinating our community. And I'm glad that many of us have taken advantage of this opportunity. So let's try to not get infected as best as we can while we live our lives as best as we can. So that we've all been thinking about it, and that's the first thing to do. The second thing would be to continue to take care of our health. Seek out help when you need to. Take your medicines, call your doctor. If you need to be treated for any problem, any inflammatory disease of the body can raise the risk of a vascular event wherever the vascular event can occur, including the brain and the heart, for example. So if we are sick, call the doctor, go to the hospital. The hospital is safe. We are taking care of you as we have always done, with your safety prime on our minds. So taking care of any symptoms by not ignoring them, whatever the symptoms are. If you have a fever, you have a cough, you have chest pain, you have stroke-like symptoms, you feel unsteady, you have a speech problem, you have maybe a numb hand, don't ignore them. If in doubt, call the doctor, because it could be a stroke, it could be a heart attack, and we want to take care of them as fast as we can so that your outcomes are good, your health is as good as it can be.
Great. And along those lines, my last question before I open it up to questions from the audience is, what can people do to actually lower the risks of getting a stroke or having a stroke?
Yeah, so the focus would be in optimizing vascular health. So what I mean by that is that we control modifiable risk factors. What would increase the risk of a vascular event? That would be paying attention to our blood pressure, paying attention to our blood sugar. If you're a diabetic, doing what you can to keep the numbers under control. Making sure we take medications to lower cholesterol if we need to. We've tried dieting, we've tried exercising, we've tried losing weight. And if that doesn't help bring the cholesterol down to where your doctor wants it to be, then your doctor might prescribe you medications, including statin drugs. And those are good medications that save lives. We do that. We exercise regularly. Vascular health is optimized by aerobic workouts. So walking, brisk walking, jogging if you want to. That's something we should be doing regularly, at least for 40 minutes a day on average would be ideal. And then sleeping well, making sure that we work on stress. We all have had a tremendous increase in stress levels in the pandemic. So what we can do to get a good outlook on life and to try to breathe in and smell the roses when we can, and be with our family and friends when we can. I think that's taking care of our emotional health, taking care of our physical health. I think we should do both.
Okay. Great. So at this time, I want to open it up to questions from our audience. If any member of our audience does have a question for either one of our speakers, please post your questions in the Q&A section of our webinar. We do have a number, so I'm going to just fire away. So our first question from our audience member. So going forward after Pfizer or Moderna vaccination, for those who think they are in the risk group for stroke and the continued slight risk of contracting COVID, what precautions should we still take? So I think Dr. Potluri, you had mentioned, getting the vaccine. You had covered a lot of those prevention and lowering risks. Is there anything else that you wish to add? Oh, you're on mute, Dr. Potluri.
Oh, sorry about that. Thank you. So like we just discussed, and I'm glad we touched on this topic just a few seconds ago, optimizing vascular health. Think about exercising regularly, beyond being vaccinated, and still being careful, within the guidelines of the CDC and our community, optimizing vascular health again. So making sure we take our medications, making sure that we are hydrated, making sure that we are exercising regularly, sleeping well. That is good for many, many organ systems in the body, including the brain.
Okay, thanks. What are the dangers of silent strokes?
Yeah, so that is a hot topic. And what we mean by silent strokes is that we are seeing some of our patients coming in with just feeling tired and exhausted, but more than that, some confusion, some disorientation, without any classic stroke-like symptoms. You don't have a paralysis, you don't have a vision loss, you don't have a speech disturbance. And these are patients who are ending up with small strokes in the brain that we discover on MRI scans. And it is part of that inflammatory process that happens in COVID. This is in patients who have had COVID. In patients who have not had COVID, but have had an MRI scan of the brain for some other reason, maybe a headache, that we would then discover these so-called silent strokes. It is our obligation as your doctors to make sure that we go ahead and treat it as if you had a symptomatic stroke. We still have to do the testing to look at the pipes and the pumps, to look at what's flowing within these pipes and the pump. In other words, looking at the cholesterol levels in your blood, looking for any markers of inflammation in the blood, and doing what we can to optimize your vascular health. It is your doctor's obligation and responsibility to address them, to make sure that we lower your future risk of a stroke. It doesn't matter if the stroke was asymptomatic. We do see that sometimes. These scans are done for a completely unrelated reason, typically a headache or a balance issue or a memory problem, something like that. And we discover these silent strokes, and we still are obliged to treat as if these were symptomatic strokes.
So do migraine headaches make you more susceptible to strokes?
Oh, that's a very tricky question. Well, it turns out, yes, the risk is not very high, though. The risk would be much higher if you had uncontrolled high blood pressure, or if you had a blockage in the carotid artery, or if you have atrial fibrillation. But migraines actually cause inflammation in the blood vessels. They cause a so-called sterile inflammation where there's no infection of the blood vessel, but there is inflammation. And frequent migraines can, unfortunately, increase the risk of stroke. That risk is much higher if you are a woman and you're taking a birth control pill, or you have had other blood clotting issues in the past, either in the family or in your own past history. The risk is slightly higher. So if somebody is experiencing frequent migraines, as your neurologist, I should try my best to try and reduce the frequency as much as we can. And there are many options to do that. Fantastic question. Yep. And if you get frequent migraines, you got to work with your doctor, work with your neurologist to get those frequencies down as much as we can.
Thank you. And here's a clarifying question. What is the difference between TIA and silent strokes?
Good question. So a TIA would cause symptoms, though. So somebody might say, hey, doc, I had some trouble speaking. My words were coming out as gibberish, and it took me about 15 minutes before I could say what I wanted to say. And then it went away, and I felt fine afterwards. It wasn't a big deal. Well, it could be a big deal. A silent stroke, on the other hand, is typically what I would use as the term to describe the presence of a stroke on a scan done for some other reason. I would not call a TIA as silent because it wasn't silent. It caused symptoms. So if it caused symptoms, you should have talked to your doctor. A silent stroke ends up being an entirely different ballgame that becomes a less urgent matter. You still have to do what you have to do. You can still do those tests and treat the patient as an outpatient. But if somebody had a TIA, I probably would want to see that patient in the ER, get some tests done quickly.
Okay. So another clarifying question is, does the migraine cause the inflammation in the brain, or does the inflammation in the brain cause the migraine? Kind of a chicken and egg scenario, I guess.
Yes, that's a really good question. So the idea here is that the current theory is that there is an abundant secretion of pro-inflammatory neurotransmitters by the brain. That these neurotransmitters, there are a bunch of them, bradykinin, substance P, there are a bunch of them. They come from the brain down the neurons, and there is nerve supply to the blood vessels. There are nerves in the blood vessels. So these pro-inflammatory neurotransmitters are sent from the nerve cells in the brain down the neuron into the blood vessel, and there they trigger this inflammation. The theories are suspecting that the process starts in the brain. Inflammation is a bystander effect that is not the cause for the migraine, that is the effect of the migraine. That said, though, the inflammation in the blood vessels may be the reason for the throbbing pain. So the pain as the symptom is coming from the inflammation of the blood vessel, but the inflammation of the blood vessel is most likely coming from a disorder of the brain.
Okay. Now, are the strokes resulting from the vaccine the same as the strokes caused by the COVID-19 virus?
Oh, another really good question, a tricky one as well. So these strokes that we see with, say, the recent strokes that we've seen with the J&J vaccine in young women, for example, seem to be from a process that is activating the clotting mechanism and causing blood clots to form either within the incoming blood flow in the arterial side or on the outgoing blood flow on the venous side. And that seems to be an entirely different beast there. There is a process where antibodies are being made in reaction to the vaccine appropriately to prevent us from getting the infection, but some of these antibodies are also then interfering with the clotting systems in the body, and that is promoting excessive clotting. And we have to recognize this carefully and early and use the right medications. The classic blood thinner, heparin, for example, can actually worsen this process. So we've learned about it, we're all very vigilant about it, and we know what to do, we know how to test for it. We have to ask the question though, if somebody comes in with a stroke, did you get a vaccine recently? Maybe did you get the J&J vaccine recently? Are you a young woman? Are you also taking maybe a birth control pill? Have you ever had any clotting issues in the past? Maybe you have phlebitis in the past. Maybe you have had unexplained pregnancy losses in the past. So if we ask these questions, then we know what the problem might be, and we know what to do about it.
Okay, and I think you hit on this about the J&J vaccine being implicated for stroke, COVID-related strokes in women between 18 to 50. Can you clarify, are these ischemic or hemorrhagic in nature? Does it mean that these are hormone-related factors? Any other thoughts on those occurrences?
So, I want to clarify that the risk of this particular complication from the J&J vaccine is still very, very low. Okay, so the J&J vaccine is back on the market. Smart people have thought about it, and the overarching need for vaccinations trumps this risk. But we have to specifically try to triage who's getting these vaccines and ask these questions. And if you are a young lady, if you're on a birth control pill, you have had phlebitis in the past, I would want you to think twice about going ahead with the J&J vaccine. So the complications are not very common, but when we see them, they can be either ischemic or hemorrhagic, because if there is a clot on the outflow side of the circulation, then the blood clot is preventing blood from draining from the brain. There is damming of the blood, and there's back pressure on the brain that can lead to a type of stroke where you can have both ischemia and also, unfortunately, hemorrhages. So you can have a hemorrhage in this context. You can have both these strokes, ischemic strokes from the clot on the incoming side and hemorrhagic stroke from a clot on the outgoing side.
Okay. Then can it result in a DIC?
Yes, that is it. That is the kicker there. DIC, diffuse disseminated intravascular coagulation. That is the process that seems to be triggered by the immune system, and that requires being very vigilant about it, testing for certain antibodies that we have known to exist in a condition called heparin-induced thrombocytopenia, or HIT. So these antibody tests can detect this particular problem, and we have these tests available in most of our hospitals, including Robert Johnson Somerset. So we call our hematology colleagues in quickly. We get the test done. We avoid using heparin, and we use different medications, and we get the input from our interventional neurology colleagues at the main hospital, at the hub hospital in New Brunswick. So that is something we're all aware of now. There has been appropriately a lot of education about it, discussion about it, thought about it. And thankfully, we know what's happening. So we're not flying blind anymore, unlike the hospitals that had to take care of these patients in the beginning, where you didn't know what to do. You would naturally be inclined to use heparin, but then heparin was making things worse. So we know, I think, a bit more about this condition, and that's a fantastic question. It is like DIC, it is like HIT.
Mm-hmm. So you mentioned prescription. So does current prescription or use of anticoagulants lessen the risks from the risks that we've been discussing here today?
Yes, absolutely. So that's part of taking care of your health. So if your doctors have deemed that you need to be on an anticoagulant or an antiplatelet medication, please absolutely take them, and that will definitely bring your risk down. Absolutely.
Okay. So, and I think the final question, because I know we've been way over, and I thank you, audience, for hanging there in with us. But this has been a very, very enriched, enlightening discussion. So the last question for today is, what are the recommendations for stroke screening?
Laura, would you want to take this question then?
Sure, why not? So stroke screening would be, like Dr. Potluri was saying, to follow up with your physician. What I always educate is to know your numbers. If you do have any of those risk factors, such as high blood pressure or diabetes or high cholesterol, you want to make sure that your numbers are under control. So for stroke screening, it would really just be to monitor your blood pressure regularly, take your medications as prescribed, and definitely follow up with your physician regularly.
And may I jump in with a quick
Of course.
addition to that? So your doctor would be checking your blood pressure, feeling your pulse to make sure that the pulse is regular, it's not irregular, which would imply a fib, maybe do an EKG if necessary, and also listen to your carotid arteries to make sure that there is no rumbling flow there, which might imply a blockage. So this is all that your doctor would be doing on your annual exam, and that is part of stroke screening. Paying attention to your vasculature, paying attention to your blood vessels, and like Laura just said, paying attention to the numbers.
Great. Thank you. Well, thank you, Dr. Potluri and Laura, for joining us today. This will conclude today's webinar. Please remember that the information presented here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. If you are interested in participating in our stroke support group, please email Caitlin Sheridan. Her email information was posted in the chat. And for more information about the neuroscience program at Robert Wood Johnson University Hospital, Somerset, please visit us at www.rwjbh.org/Somerset. On behalf of Robert Wood Johnson University Hospital, Somerset, thank you for joining us today and have a great afternoon. Be safe, everyone.
Thank you.